Okay, let's dive right in. We are going to build a survival guide for one of the most common and, let's be honest, sometimes most dangerous consults you'll get on the wards: dermatology. Picture this. You've been on call for what feels like an eternity. It's 2 a.m., your pager goes off. A nurse asks you to come see a patient with, and I'm quoting here, itchy red patches. Yeah, we've all been there. And that's the million-dollar question, right? Because that innocent-looking rash could be anything from a simple contact allergy to the very first terrifying warning sign of a life-threatening systemic infection. Knowing the difference, that's everything. So that's why we're not just going to list a bunch of rashes. No way. We're going to build what I call a ward-ready mindset. Think of it as a framework for your brain, a way to connect the dots from a simple rash to a potential red flag. So, what does ward ready actually mean? Well, it's about seeing the skin not as this isolated organ, but as a window into the patient's entire health. It's all about safety, avoiding those common mistakes, and knowing exactly when you need to pick up the phone and escalate care. And this whole mindset really rests on 3 core pillars. First up is integration. That's understanding how a systemic disease like diabetes can literally fuel a skin infection. Second, there's safety. Knowing how to dodge major errors like Tinea Incognito, the kind of stuff that leads to lawsuits. And third, escalation. Being able to confidently spot when a non-healing wound might actually be a malignancy in disguise. All right, let's get into it. First up, the most common call you'll ever get, the itchy rash. We're gonna decode the itch.
Okay, I want you to do something for me. I want you to commit to an answer right now. You're at the bedside, you're looking at an itchy red patch. What is the single most important, the very first question you ask the patient? Go on, lock in your answer.
If you said how long have you had it, you are absolutely spot on. Onset and duration are your first most critical clue. Think about it. An acute rash, something that's been there less than 6 weeks, immediately points you towards things like urticaria or an allergy. But if it's chronic, lasting more than 6 weeks, your brain should immediately jump to eczema or psoriasis. Just that one question cuts your differential diagnosis in half. Boom. But, it's not enough to just know what to ask. We need to understand why. And to make this really stick, let's use a little analogy. I want you to think of the skin as a big, well-defended castle fortress. So, in eczema, the problem is the castle walls themselves. We're talking about genetic mutations in a protein called filaggrin, which basically means the bricks and mortar of your skin barrier are weak. This lets precious water escape, causing that awful dryness, and it lets the enemies, allergens, and irritants just walk right in, kicking off inflammation. So the treatment makes perfect sense, right? You have to rebuild the wattle with things like emollients. Now, urticaria, or hives, totally different story. Here, the castle walls are perfectly strong and intact. The problem is happening inside. The guards, your mast cells, are completely panicking. They overreact to some trigger and just flood the castle with histamine, which causes all that swelling and that crazy itch. So the treatment isn't about fixing the wall, it's about calming down the guards. That's where antihistamines come in. Okay, now that we've got the basics down, let's talk about the true emergencies. These are the red flags you absolutely, positively cannot miss. If you see swelling of the lips or eyes, that's angioedema. That is an airway risk. Stop everything, call for help immediately. Next, if you press on the rash and it doesn't turn white, meaning it doesn't blanch, that's called purpura. This isn't just inflammation, it's a potential bleeding or platelet problem. You need to check labs right away. And finally, if there's a fever involved, you have to investigate for something systemic like vasculitis. All right, we're shifting gears now and heading into the danger zone: skin infections. The stakes get a whole lot higher here, and the potential for making a mistake is, frankly, significant. Before we go any further, I want this warning basically burned into your brain. If you even suspect an infection, do not reach for that steroid cream. This is probably one of the most common and dangerous pitfalls in all of medicine. And that leads us to this simple, crucial rule. Just remember this: if it scales and itches, scrape it before you steroid it. Say it with me. If it scales and itches, scrape it before you steroid it. And here is exactly why that rule is so important. This is Tinea Incognito. It's what happens when you accidentally put a steroid on an undiagnosed fungal infection. See, the steroid dampens down the inflammation and redness, so it looks like it's getting better. But underneath the surface, you've just suppressed the body's immune response, allowing that fungus to grow deeper and spread like wildfire. This is a massive medico-legal risk.
So how do we avoid guessing and getting into that mess? Simple. We used the diagnostic triad. This is your toolkit. A KOH prep, just a simple scraping, is over 90% sensitive for fungus. Easy. A PCR swab is your go-to for viruses like herpes or varicella. And if you see pus, you absolutely must sample it for culture and sensitivity. That's how you identify the bacteria and pick the right antibiotic.
Okay, let's talk about another critical, time-sensitive diagnosis. When it comes to shingles or herpes zoster, you are on a clock. The countdown has started.
The classic presentation is this painful cluster of small blisters that follows the path of a single nerve, what we call a dermatome. Now, the key takeaway here is you must start antiviral treatment, like acyclovir, within 72 hours of that rash showing up. Why? Because doing that dramatically reduces the risk of the patient developing that debilitating chronic nerve pain called post-herpetic neuralgia. That 72-hour window is everything.
Okay, deep breath. We've covered a ton of ground, so let's pull it all together into a final, rapid-fire algorithm you can literally use on your next shift. This is how you get ward-ready and confident. First up, you see an itchy, ring-shaped lesion. It's got a little bit of scale. Before you do anything else, what's your action? You grab a slide and a scalpel. You do a KOH test to rule out tinea. Period.
Next scenario, the patient has these itchy welts or hives that seem to come and go within hours. Classic urticaria. What's your action? You calm down those panicking mast cells with a non-sedating antihistamine like fexofenadine. All right, next, you walk in and see a patient with painful blisters tracking along one side of their body in a clear nerve pattern. That's shingles. Your action, you start a acyclovir stat. Don't you dare forget that crucial 72-hour window to prevent long-term pain. And finally, a super important one about chronic wounds. If a patient has an ulcer or a sore that just will not heal after weeks of good care, you have to think beyond just infection. Your action is to biopsy it. You have got to rule out an underlying skin cancer, like a squamous cell carcinoma, which can sometimes disguise itself as a simple wound. So the next time you get that 2 a.m. page for itchy red patches, you're not just going to see the skin, you're going to see the system. You'll have a framework to think, to act, and to escalate with total confidence. The only question left is, are you ready?